I came up with a topic which look into mindfulness-based intervention from a life course perspective. So, so first of all, I need to just recap the definition of mindfulness for people that who may not be as familiar with the definition from a point of view of many of the evidence-based intervention that has been conducted. So mindfulness is the awareness that arises from paying attention on purpose in the present moment, non-judgmentally, in the service of self-understanding, wisdom, and compassion. And that was given by Dr. John Kabat-Zinn in the Mindfulness and Learning Interdisciplinary Symposium hosted by Johns Hopkins University in 2014. So, as you know, public health is broad, and we do see a lot of different mindfulness programs in various settings and in different ages. So sometimes it's very difficult to look into how we organize our thinking in terms of on which population, on what intervention to use, especially using an evidence-based approach. So we have the life stage, and at different stage, there are different influencers. So we have the childhood and the influencers, or things that can affect someone's health outcomes, including the parents, schools, maternity and childcare services, and public health initiatives. Adolescence, where parents, school and universities, wider family and social support and healthcare services, and also social media now may play a very significant role. Adulthood, including the work environment, family and friends, healthcare services, and also society and media, and then older people, including wider family and friends, healthcare services, and also society and media. And you can see that at different life stages, there are different influencers. And therefore, when we look into the mindfulness interventions of more than 1,000 per year now, sometimes we need to look into the evidence-based to see which interventions are best for which population. As you know, there are many mindfulness programs now. And when we look at that Google to take a look and you type mindfulness, there are so many things comes up, including some of the easy to read for our everyday use, for example, finding peace in the frantic world, or there are other programs for different ages. For example, My Mind for ADHD and ASD, mindfulness-based cognitive therapy for people with depression, and recently also there's a mindfulness-based cognitive therapy for life, which is for people targeting on a more healthy population. So with this, so many different programs being available, sometimes it's hard to know which programs are more evidence-based and which program we should use for which populations. So in this presentations, I would like to give you a life course perspective from being someone not born yet, when someone is pregnant, to being a parent, to someone with some learning disabilities or in a very young age, to schools, and also to adults, and also to elderlies. So, but one thing I need to give you some information on my presentation is that my focus is mainly on mindfulness-based stress reduction, which is a program started in the 1970s by John Kabat-Zinn, consisting of 8-week course, which is a secular approach to teaching mindfulness meditation, and also mindfulness-based cognitive therapy, which was started in Oxford, Cambridge, and Toronto, psychologists in the early 2000s, and are based on an empirical approach showing depression relapse is related to automatic thoughts and how Mbcd has been used for depression later on. So all the evidence that I'm going to present will be based on this 2 main mindfulness-based interventions. So some of the, just refresh your memory, mindfulness-based stress reduction was started in the 70s. In fact, at the basement of the hospital for looking into people with both psychological and physical problems, including chronic pain and anxiety. And it's 8-week programs with each week lasting for about 2.5-hour sessions. And it consists of body scan, sitting meditation, mindful yoga, walking meditation, regular daily practice, including formal and informal meditation practice at home during everyday life. And that's also a retreat lasting for about 4 to 5 hours in addition to the 8-week sessions. So people may ask, what is the theoretical basis for how mindfulness-based intervention works? And more research showing on various domains, including neuroscience, including clinical medicines, including psychology, thinking about that how mindfulness changed the automatic inference processing may be one of the keys by increasing awareness, attentions, and also our acceptance. So by affecting all these different psychological systems, there may produce some desirable health outcomes. Although I'm saying that this is one of the theoretical bases, there's still no definitive confirmation of which process are mainly responsible, although many research has been conducted to suggest various processes. So take a look at the breadth of research or interventions that using the mindfulness-based interventions in various health outcomes. This recent meta-analyses consisting of 336 randomized controlled trial of more than 30,000 people published in 2021, just to do that, to describe using the PICO approach. So for people who are not familiar with the PICO approach, this is a common framework or procedures that we use in scientific research by looking into the population, interventions, comparison, and outcomes when we look into the evidence-based effectiveness or efficacy of interventions. And some of the results from this large study showing that mindfulness meditation holds substantial transdiagnostic potential, and the utilization of MBIs are a family of interventions that partially supported by scientific evidence. And I will tell you more why they said partially supported. But the concept of transdiagnostic potential, meaning that you can use the mindfulness interventions for a variety of psychological disorders. So this is a diagram that is in the publications that shows the breadth of research studies have been done using mindfulness-based interventions. So in terms of the population, you can see that it's been used in older adults, adult students, employees, healthcare, and children. So you may ask, what's the difference between A and B, the slides on the left versus the right? The left one, you can see that the effect size in general on some of the conditions are slightly more. It's because the fact that they're comparing to passive controls, meaning that non-specific effects are not controlled for, while the diagram on the right side are comparing mindfulness-based intervention with active controls. So, and this is from pre and post treatment, and the figures can be read that the effect size, if they are more to the right, meaning that the effects are bigger. And you can see that for some of the interventions, such as Mbcd, the effect size, when you compare to the active control, is much stronger compared to some of the interventions. Although you might not want to specifically looking into the details, because this is a graph that shows you a lot of information. But the reason I want to include this is to show that the population investigated has been covering a large different populations, and the problems that's being covered, including depression, smoking, substance use, cancer, psychiatric disorders, physical disorder, and anxiety, while the intervention covers, including Mbcd, and more recently on some of the mobile apps intervention on health outcomes. And for the outcomes, that consists of stress, physiology, psychological symptoms, and also sleep. Although you can see that for the effect size, it does vary by what kind of conditions we're talking about and what kind of interventions and outcomes we refer to. So that is just to give you an overview of the number of studies and the breadth of the intervention and population that have been published. But I'm going to walk together with you on the life course approach related interventions on using mindfulness-based intervention. So the first intervention I want to talk about is for perinatal and childbirth mindfulness-based interventions. So previously, there's this systematic review published in 2016 looking into the effectiveness of mindfulness-based intervention for reducing depression, anxiety, and stress on the perinatal period, which is prenatal, when someone's pregnant, to 1 year after childbirth. And this is a studies that look into both qualitative and quantitative studies look into the effectiveness of using mindfulness-based intervention. So in 2016, there were about 595 for the population with 17 studies. However, but at that time, you can see that most of the trials were using waitlist control. And now in behavioral research, waitlist control now is not considered to be in terms of very high evidence base, simply because sometimes when people are waiting to get the intervention, they're likely to have slightly worse outcomes. So when you give them an intervention and you compare that to waitlist control, often you will get positive results. So, and the types of interventions, again, there's a relatively large scale of heterogeneity, and many of them were published on post and pre and post results. So mindful childbirth is one of the more structured interventions that people have used in the literature to see whether it works for people who are pregnant and to see whether there's postnatal outcomes impact. So some of the introduction and refreshment, mindful childbirth, the aim is to cultivate mindfulness to cope with stress, fear, and pain related to pregnancies and childbirth and parenting. And for those of you who are parents, especially women, you will understand that getting pregnant and having a baby sometimes is very stressful. And so this program, the intention was to have a 9 weeks intervention, 3 hours each time, with a silent day-long retreat with the partners to see whether it can improve and reduce the stress and pain associated with pregnancies and childbirth. So we have also done this in Hong Kong, and this is Hong Kong in one of our a room here, and this is the instructor, Katrina Zhang. And some of the specific components with this program, and in fact, this program is started with some modification from the Mbcd, and looking into some of the pain, partner communication as the usually the partner was around, and also the community. So we conduct a randomized control trial comparing with an active control group, which is antenatal childbirth education support. So the reason we include an active control group, because we really want to see whether the mindfulness intervention is better or even the same for what we routinely offered for people who are pregnant. And we included the singleton pregnant women who are residents here with no previous meditation experience, having a concurrent psychiatric disorders with exclusion criteria, because we really want to look at healthy populations and see whether it can improve their well-being. So we use the mental health SF-12 as one of the outcomes. We also use secondary outcomes because we understand that sometimes women may experience depression or anxiety when they are giving birth to babies or in the postnatal periods. And this is RCT comparing with active control. We randomized 183 people. Although we have a problem in the follow-up, and when you look at it carefully, we have a bigger dropout in the intervention group compared to the active control group. So this is the outcome that we have. We've shown that on the follow-up, because we have a baseline, the first follow-up was after birth, and the second one was 2 to 3 months, actually 2 months after the childbirth, and then 6 months after childbirth. And you can see that at the 6 months childbirth, we see an improvement in the mental well-being, although we only see that in the 6 months time. Although for depression and anxiety, it seems to start having an impact on after childbirth and later on. So T2, T3, and T4, where we see impact. And also for the mindfulness levels, and also on prenatal anxiety. Although, unfortunately, we don't see that in the partners for this intervention, and we look into other outcomes, including whether there's a change in pain level on the childbirth or other outcomes such as obstetrics outcomes, and we fail to find any differences. So these are the key findings from our work, that we find that there's improved mental health 6 months after childbirth, while it seems to have some reduction in depression, anxiety, and increased mindfulness level even prenatally after enrolling in the intervention, which persists and sustains until 6 months after childbirth. We don't see any beneficial effects on obstetrics outcomes, and it seems that the program was well accepted on the feedback, although we found that there is a high dropout in the MBCP group compared to the active control group. So this mindful childbirth has also been used in Sweden. And recently in 2021, there's a publication published in the Mindfulness Journal looking into the long-term effects of MBCP and parenting program, again, among pregnant women. And this is the results. So initially, this is the perceived stress scales. This is the Edinburgh depression scale. This is the mindfulness scale, and this is the profile mood scales. And they found that there's a significant reduction and improvement in terms of the mental well-being and depression reduction during the first after the intervention. Although this positive impact was not sustained later on when they followed the same group of people over 12 months time. And when you look at the results, you find that one of the findings is that people stop practicing after the intervention, which may account for the lack of sustainability over the 12 months period. So the conclusion from this study is that the partial support for providing MBCP for pregnant women, although the initial beneficial effect seems not to be sustained over the 12-month period, although it seems to have some improvement significantly during the first postnatal period. And the authors argue that since it is within this critical period that might be important for the long-term outcomes, so they suggest that this is still useful to use it for pregnant women. So we learned a little bit about the mindful childbirth. And in this area, as you know, there's a lack of active control, and those two studies that I discussed are using active controls as comparison. And I believe that we do need more studies in these areas to confirm the positive impact. Next, let's talk about mindful parenting and my mind interventions for looking into adolescents with learning disabilities. So the first one I want to talk about is for mindfulness-based intervention on childhood attention deficit hyperactivity disorders. So this is Professor Susan Bogos from the Amsterdam. Many of you might have known her. She came to Hong Kong actually 4 times already. And she came to help out with establishing the Mind program in Hong Kong. And quite a few years back, this was published in 2017, and she came in 2016 and 2015. And this is published in Mindfulness to start a pilot study to look into whether we can use My Mind translated into our local dialect for children with ADHD, especially together with the parents, part of mindful parenting. So this is an 8-week program with some of the modification again from the MBCT. For example, week 1 is from Mars, My Body, My Breath, Distraction. So many of these programs have some modification from MBCT. For example, this program for the children exercise, it is much shorter because these children are affected by attention deficit and hyperactivity disorders. And for the group size, it's also much smaller. So for example, when we ran this group in Hong Kong, this is about 5 children per group. While for the parents group, they are combining two small group in children and the parents coming together on using some of the mindful parenting, which is about 12 people per class. And there are 3 classes where both parents and children are doing it together, such that they can translate that when they're practicing at home. So again, the attention was on automatic piloting and responding and some of the practices. So this is again some of the photos we took here at the School of Public and Primary Care. And when you look at the literature, you still see that more randomized controlled trial is needed. So this is a relatively small studies on 30 children and parents, randomized control with a weightless control. And after the program, the parents report a decrease in parenting stress, improvement in parenting skills. And after 6 months, there's still some maintenance in the improvement. Although again, this is comparing with a weightless control. And we do need more studies comparing with active control in these areas. And I believe that Professor Boggles have done one, and hopefully will be published and we'll be seeing the results comparing that to medications. This is a meta-analysis published just last year, consisting of 21 control studies ranging from 3 to 12 years old. And you see that the target is on more of the younger population with ADHD, simply because I believe when I talked to Susan that when you target the ADHD who are adolescents, who are older, they might not it's much harder to recruit them. So this systematic review consists of RCT and quasi-experimental design. And this is one of the problems when you look at these systematic reviews, that they consist of various study design, which make it hard to put them together to have very confirmatory results. And we use the word heterogeneity to describe this problem in systematic review. Although this review has shown that the MBI seems to decrease children overall in attentiveness and ADHD behaviors, and the outcome measures mostly were rated by teachers, so there's relatively lack of studies using rating by other objective measures, although it seems that it does have a moderate effect in reducing inattentiveness and hyperactivity. Again, we do need more studies compared to active control and also with more objective outcomes. So this is a study that we have conducted in Hong Kong. We still haven't finished that, and my PhD students are doing with a target to about 100, and in fact, our target is about 130 to 140 people. And so far, we compare it to a group CBT approach. As you know, CBT might help people with the some of the behavioral issues. And so far, we did not see a difference between the mind group and the CBT. And for within difference, the CBT appeared to do it slightly better. So we still need a bigger sample size to know whether CBT are in fact better or there's actually no difference between the two groups. Although qualitatively, we do get some positive feedback from parents and children. And in fact, many of the changes that we see are in the parents. It seems that the parents seems to develop acceptance on their children's behavior over time and on the relationship between the spouses. So the next, we look into MBI on child adolescents autistic spectrum disorders. And these are older children, ranging from age 12 to 18. And the first, we look into the systematic review and meta-analyses published in 2019. Again, they're consisting of randomized controlled trial and quasi-experimental design with 10 independent studies. So the learning here is that there are not many studies in this area, and when there were, they might not be on a very rigorous design. Although the preliminary results show there is significant improvement in the subjective well-being, it doesn't seem to improve so much on the behavioral aspects or the disorders, although many of the outcomes which are positive is on the reduction on the mental anxiety or improvement of well-being. We have also done a pilot in Hong Kong a few years back, published recently in the Journal of Autism and Developmental Disorders last year, but on a very small scales. And we did a randomized control trial with a pre and post design with a 9-weekly 90-minute group sessions. working with Susan and Esther. Esther is the person also from Amsterdam who are more interested in ASD using my mind interventions. And we've shown that it's appeared to be feasibility with no problems. We have a very high attendance rate, over 80% in the adolescents, and with a very low dropout rates. Although for the effectiveness, our sample size were a little bit too small to see any differences. Although that appears to be a trend in terms of reduced parental stress, improving parental styles, and reduce rumination and improve mental well-being. Again, we will need a bigger studies to be able to more conclusively showing the results. So next, we go into schools. And I believe that in this week and last week conferences, we have been hearing some presentation from mindfulness in schools, and tomorrow another professor from Hong Kong U will be Professor Lam will be talking about some of the projects she conducted in Hong Kong in mindfulness in schools. So for the people who are not familiar with mindfulness in school, so basically this is a large program that was started in the UK, which has been planned over the last decade, since early 2010s, by the group by William Coogan. Now it's Oxford, and I believe initially was University of Exeter. And this is a mindfulness in school project which consists of 9 sessions, including 1 presentation and 8 further sessions with 75 minutes duration. And the interesting part of this program, which you might have heard is called .B, is that some of the projects, some of the interventions are more a little bit of a presentation style, with the first sessions being the presentations, and this is and the wish was that this to be integrated within the school curriculum with home practice. And the first publication that I found from this group is from 2013, the British Journal of Psychiatry, to look into the feasibility and acceptability of doing that, which was quite positive. So, and this is again because of the feasibility nature, this is more of a pre and post intervention results with fewer depressive symptoms on post-treatment and follow-up, and lower stress and greater well-being. Although we need to take into mind that when you're doing feasibility, there might be a substantial systematic bias, because people who are joined and attended may be more willing to practice, and they may be more willing and pay more attention to what they do. So that's because of that, a larger study on a larger scales is needed. So the next step was to look into a non-randomized feasibility trial, looking into the efficacy of mindfulness-based intervention for teachers to reduce stress and improve well-being. So previously was done in children, and now this is done in teachers. So the non-randomized design, again, is a limitation of the design. Although if you're looking at the feasibility, this is what should be done. And the sample size was relatively small, but again, it's good for feasibility and it's relatively large for feasibility studies. And the results, again, is quite positive, report significant reduction in stress, significant increase in well-being, with a large effect size, with the majority of teachers who attend the course find to be acceptable. So now all these positive results conclude that a larger scale randomized controlled trial was needed. And the Wellcome Trust has funded such a study with £6.4 million on a research program carried out by Oxford, UCL, and also MRC Cognitive and Brain Science Unit together with University of Exeter. I believe they started this trial on a very large scale, consisting of several thousands students and also their teachers in more than 76 mainstream schools. So 38 schools were trained among 11 to 14-year-old students in mindfulness, while 38 schools were acting as control groups. So this is truly large studies, randomized design, regular studies, which has begun in 2016, has been going on for 5 years. And I believe during the COVID, there may be some modification, but I believe we'll all be excited to hear the results from these studies, because I believe this is one of the biggest studies in the history on school students. So other systematic review has been conducted on post-secondary students. So this population is on university, on 41 studies, more than 4,000 students for undergraduates and others, and appear to show that there will be reduced with symptoms of depression, anxiety, and perceived stress. Although one of the comments from the author is that many of these are very low quality evidence, meaning that many of the comparisons were not with active control groups. So sometimes it's very hard to know whether the positive outcomes is from non-specific effects, like being in a group context, or simply because of Hawthorne effects, or other effects simply because of historical improvement. So again, more studies are needed in this area, although it appeared to be positive in terms of the preliminary results. They also shows that some MBIs of at least 2 weeks is needed to appear to be a good alternative to no intervention for students with symptoms of depression, anxiety, and perceived stress. Next, we will go into adults. And the first studies I'm going to show you is very relatively large studies, and I believe one of the most important studies published over the last decade from the Oxford group, from Professor Coogan's group, published in 2015, I believe with also University of Exeter and other universities in the UK, on the effectiveness and cost effectiveness of mindfulness-based cognitive therapy, comparing to maintenance antidepressant in the prevention of depressive relapse. Now, many of us who are clinicians knowing that if someone's presenting with more than 3 previous episodes of recurrent depression, it does may require lifelong antidepressant treatments or CBT as evidence-based interventions. But for these patients, many of them do not like to be on antidepressants for life. And so that there is a need to look into other alternatives where you can reduce simply the reduction of the episodes of recurrent episodes of depression. So these studies were just to prove that on a very large scale using a rigorous design. So their group have done is to have conducted a randomized control trial recruiting patients in primary care settings to look into those who have recurrent depressions and comparing that to an arm who are on maintenance antidepressant treatment with a slight tapering protocol. And this is the result showing using the survival curve over a 24 months period to show that there were no significant difference between those who are on maintenance antidepressants comparing to those who are on Mbcd. So initially, when they did the studies, they actually intended to show that Mbcd was better than antidepressants, although in the end, they didn't show a difference, which might affect the sample size a little bit when you're calculating the sample size to show superiority. And in the end, I believe this is more a non-equivalent trial to show there's no difference between the two groups. And they did show that there's no difference in terms of the relapse rate between those who are on maintenance antidepressants and using Mbcd. Although I believe in the health services perspective, this is a very important study because you do want to know whether you can use Mbcd when the patients are willing to do that and they're happy to do that with a good compliance while they are on a tapering regimen to reduce antidepressants when they're taking planning for many years. The next study I want to show you is again by Professor Coogan's and a group, including other authors who have previously done a trial in Mbcd, including one from Hong Kong, Helen Ma, who was actually, when she conducted studies with Professor John Teasdale at the Cambridge during her PhD program. And this is a very unique study simply because they use individual patient data, which is very hard because you actually need to collect the individual patient data instead of it's just not a regular meta-analysis because it's a similar doing some raw data analysis. So in terms of the level of evidence, this actually provides stronger evidence compared to other meta-analyses. So this is a meta-analysis, and they use individual patient data, RCT with a manualized approach. So these are all structured Mbcd, again, which is more rigorous in terms of the evidence base. And they compare Mbcd with at least one non-Mbcd interventions. So the strength of these studies is that it is large. It's more than 1,000 subjects with 9 studies. And so that can provide very conclusive evidence and results. So they show that Mbcd has a reduced risk of depressive relapse over a 16-week period. And compared to those who did not receive the Mbcd, many of these comparisons were with active treatments, with a relative risk reduction was about 21%. And this is a forest plot showing the results. So for people who are not familiar with the forest plot, you can look into the reductions in terms of risk of having a relapse of depression. So basically, the larger the reduction, the better. And if you have showing no difference, then that would be 1. And the larger, this is called the sort of the confidence interval. If the larger confidence interval basically showing that there's a big range of results. And so if that larger confidence interval touching 1, that means that that is not statistically significant. But when you pool all these results together, because some of the sample size were relatively small, you are able to achieve a bigger sample size looking into the conclusive evidence. And this is exactly what is shown. And this is an Mbcd versus no Mbcd. And you show the effect is relatively large with about 31% reduction. But you don't just want to show with no Mbcd. You actually want to show that Mbcd is better or the same with active treatments. And they are shown that it doesn't touch 1. So that's a reduction of 21%. And even showing that with antidepressants, there's a reduction in 23%. Although you can see the confidence interval is reaching almost 1, meaning that there's actually not much difference when compared to Mbcd with antidepressants, if it's not better. So I believe this research does show that Mbcd is very similar to having maintenance antidepressants when someone with recurrent depression. And so this is good for patients, and it's good for health services system. And as you know, the NICE guideline now recommending that Mbcd now is good for people with previous episode of depression, and now they can actually be provided for free when they are referring from general practitioners on people who have recurrent depression, which is a very good step in terms of how we can bring mindfulness using evidence-based approach into mainstream psychological interventions and treatments for people with recurrent depression. So one of the questions that we might have is the time trend. As people who are in psychology or in psychiatry or in mental health research, knowing that recent meta-analyses looking into the time trend on cognitive behavioral therapy have shown over the last 2 decades or 3 decades that there's a decrease in the evidence base of using CBT on the improvement or reduction in depressive symptoms. And one of the comments may be the fidelity of how people are being following the approach on CBT in the community. So recently, a publication in a Scandinavian Journal of Psychology have done a more short-term time trend on mindfulness-based cognitive therapy, about 1 decade, 10 years, to show that whether similar trends happening in Mbcd when compared to CBT. So they did, and they used the method of comparing Mbcd to passive active control and looking into the pre and post differences. But the only difference is that instead of looking into the previous episode of recurrent depression, they look into the current depression or elevated scores. Because this is a little bit controversial in terms of that we have been recommending people with recurrent depression to use the Mbcd in terms of the most evidence-based. But seems that this research shown that people with current depression may also work. And the conclusion they have is showing that Mbcd is effective in reducing depressive symptoms, while the outcomes measures is back depression inventory or using the Hamilton Depression Rating Scales, which is clinician rating scale on the reduction of depressive symptoms. Although the number of studies were small, they did not show a decrease in terms of the evidence base or effectiveness when they are using the Mbcd on reducing depression among people with active depression. So I think this is a good, at least preliminary findings of more than 1,000 participants on 20 studies to show that there has not been a reduction and it might work for people also with active depression. And again, this is a forest plot. Again, when you are comparing Mbcd with other intervention, So you can think about this as the effect size using the meta-analyses, and when they are favoring A and B, meaning that favoring B meaning is favoring MBCT. So the more to the right means the effects are stronger. And the upper diagram was showing with no treatment controls. Of course, when there's no treatment, usually you have a bigger effect size. But even with active control, you can still see there's a mild to moderate impact, showing that MBCD is actually perhaps a good intervention over time, even for people with active depression. The next, I would like to show you the MBCT for prevention on depression relapse using a network meta-analyses. As you shown, some of the bigger trials or the inpatient data showing that MBCT does work well for people with antidepressants and also with other active control. And this is meta and network meta-analyses showing that MBCT again is far more effective among people when they're comparing treatment as usual in the long term. So this is more of the long-term impact because you want to see assessment on over 12 months or longer term, while there are relatively fewer studies have been following these patients over long term. So, and it seems to have a statistically significant advantages over treatment as usual and placebo for prevention of times of relapse, even over a 12-month period. And if you look at more into the details, you can see the comparison group. So for treatment as usual over the long term, more than 12 months, it seems is a significant reduction. And although there's some suggestion, this is a comparison that's interesting because the intervention group is MBCT, while the control group, they actually have antidepressants with MBCT. So this suggests that maybe for people who need maintenance antidepressants, adding MBCT to that may be even more effective compared to just MBCT. So this will require more intervention because there's simply lack of studies comparing that. And there's only one study, although relatively large sample size, to compare that. While the other studies, they didn't find much difference in terms of the active control, including cognitive therapy, including maintenance antidepressants, including cognitive psychological education, etc. So, and this is the meta-analyses, and network meta-analyses should show the comparison with relapse of depression and control conditions. Again, it seems that many of these studies didn't show much difference between the active control, while the effects are much better when you compare to a placebo, and it favors control only with a trend when you compare the MBCT with antidepressants plus MBCT in these graphs. So the upper graph are the one with meta-analyses, while the lower diagrams are the one with network meta-analyses. When you pull them together to look at which intervention and which control groups appear to show a better effect size. So what about MBCT for anxiety? It seems that there's a trend for effects. And we did a study in Hong Kong, published in British Journal of Psychiatry about 5 to 6 years ago. And we conducted a randomized control trial with 3 arms, MBCT versus psychoeducation group using the CBT principles and usual care group. And we followed these patients 3 months, 6 months, and 9 months. Although the comparison group with the CBT, with the usual care ended at 6 months because we think it's a bit unethical, because the waiting time for Hong Kong to see a psychologist is back then was about a few months, and now it's even longer. So we thought we'll end the usual care arm earlier on. So we have 3 arms comparison, and we've shown that for anxiety, appear that there's no difference with the MBCT and psychoeducation with CBT principles. And in fact, there's slightly advantages for the CBT group compared to the MBCT group, although both groups appear to be much better with usual care. And unfortunately, usual care in the public clinics in Hong Kong is usually just monitoring for these people because we do have a relatively long waiting time to be seen by psychiatrists or psychologists in our primary care settings in the public sector. So we talk about mindful childbirth, we talk about a special needs group, we talk about adults of Mbcd and MBSR. So let's talk about the final population is among older adults using mindfulness-based stress reduction or mindfulness-based cognitive therapy for older adults, and which is again an interest. I personally am interested in it. We're conducting an RCT on loneliness to see whether mindfulness-based cognitive therapy can reduce loneliness among adults. So the training for older adults, theoretically, you're thinking about psychological health. For example, in Hong Kong, our older adults have a high suicide rate compared to other population age group. And one of the problems in older adults, of course, is that they have chronic diseases. Many of adults, many of the younger population are moving out from the older adults, so they might experience loneliness. And because we have one of the longest life expectancy in Hong Kong, many of the spouses do faces living alone in relatively poorer conditions. So, and of course, another issue is cognitive decline. So some studies investigated whether mindfulness-based interventions can improve or reduce the cognitive impairment. So the first set of studies were on depression and anxiety in older adults. So for example, effects of mindfulness meditations on depression in older adults in meta-analyses. One of the things you have to note is that many of these studies were published relatively recently. For example, these studies were only published recently in 2020 on the meta-analyses looking into older adults 65 years and older, with the outcomes being depression. There's another study I looked into published in Mindfulness last year on looking into the depression and anxiety, but I picked these studies because I think this is a relatively larger, and the intervention and the population we talk about is more focused on depression, with more than 1,000 studies showing that there's significant improvement in depression compared to controls. While in the moderator, they appear that it works in Asians slightly better than other countries. And interestingly, they show that shorter intervention appear to show greater improvement. And I'm not sure why this is so, and they might need bigger studies with better active control to conclude the effects. So these systematic review conclude that this is more preliminary, although that some of the learning points from that is that in older adults, maybe a shorter period may work better, a guided definitely work better, and then might work better in Asian populations. So this is the forest plot. Again, I'm sorry about this, is a bit blurry, but this is what I got from the publication. It's also a little bit blurry, but it shows that this is more on the right side, showing there is improvement in terms of the depression symptoms compared to the control group. Another studies that we conducted quite a while back, about 8 years ago in Hong Kong, is to look into caregivers. As you know, there are more people suffering from physical conditions when they are entering old age. And many of these people need to look after older adults who have physical disabilities, for example, with stroke or cognitive impairment, etc., at homes. And many of them have no other care providers except other older adults who are their spouses or their family members. So we look into whether we can provide MBCSR for caregivers who are also older adults. So initially, when I did this randomized control trial, many of the people were worried about that these caregivers may not have time to come to join MBSR, but indeed, we find that it was feasible. And many of these caregivers indeed have depressive symptoms, and they have burnout from caregiving. And many of them have depressive symptoms. And we show that post-interventions compared to control group, I have to admit that we did not have a very active control. What we did is to have some slight psychoeducation with some pamphlets given them over time. So you can see that this is a very mild form of control group, and active control is needed. Although with such a mild control group, which shows that there's improvement in terms of the depressive symptoms in the MBSR group, which was sustained in a significant proportion over 3 months period, while we found the control group has some deterioration. So I sort of carry you over on from a young population using mindfulness-based intervention to older adults. And I want to summarize for you is that the strongest evidence, again, is on recurrent depression, although there's some more evidence showing that this is even for active depression, and also for some of the population, including anxiety and some of the substance abuse population. More studies are indeed needed using some of the approach that has been showing on recurrent major depression for comparison to evidence-based intervention as comparison for health problems. And one of the problems that we've seen in many of the systematic review, I don't think we need to do more systematic review on many of the studies, because there's simply not enough studies with a proper or rigorous design on some of the population we talk about. So that we should conduct studies with better design, especially on a control group, in order to have better systematic review with a lower heterogeneity. And other areas of research that is needed is, for example, to have a better measures of compliance when you are conducting the mindfulness-based interventions. And the other studies that are needed is to show who maybe benefits the most. As some of the study previously showing that people with more severe symptoms may be the one who benefit the most. And what is the proper duration is needed. And even when you're talking about the homework assignment, whether it's 45 minutes too long for some of the people, which we often see, and how the practice time will have an impact on outcomes. And we're looking into mechanisms, maybe qualitative studies will be needed in order to show which aspects of the interventions are both beneficial for maintaining the improvement over time. So again, I need to thank many people who have helped me. For example, Dr. Hanlema, who brought mindfulness training in Hong Kong, and also many of the people and folks from various countries, including Susan Bogos in Netherlands, and Larissa Duncan, who came to Hong Kong many years ago, and many of the health professionals, including social workers, my previous PhD student, Rebecca Howe, and many of the psychologists who have worked with me, and psychiatrists who have worked with me over the years to produce many research ranging from children to people with chronic pain, insomnia, anxiety, recurrent depression, older adults, and now on substance abuse, smoking, as well as older adults with loneliness, and now on PTSD. So I need to really acknowledge their support over the years. And this is our team. And this is Hong Kong. Regarding COVID, we are pretty well controlled. We only have a few cases per day. Although we have a relatively long quarantine period, which I hope that we'll be able to lift that in the future. But I hope that you can come to Hong Kong to visit our centers and to collaborate with us with the center, Thomas Jing Centre for Mindfulness Research and Training, which is a center situation in Central, which is right here in one of the busiest areas in Hong Kong. And so I want to thank you for listening over the past 1 hour.